do today is kind of have a conversation with you guys about some of the issues that we talk about a lot and that we're concerned about. Those of you who are not at this site probably haven't seen that we have set up a clinic where I have additional time to see patients above the typical schedule, and Jose is available for supervision as needed. By doing that, or the kind of part of our reason for doing that, is to try to figure out, like, what would additional training in psychiatry look like for a primary care physician, the same way that we have additional training in obstetrics and we have additional training in HIV care. So, you know, what would be most useful to focus on when you're thinking about that, and what would be most useful, you know, in a primary care practice like ours. And we definitely feel like it's a work in progress to figure out what that would be, because there's not around the country, like I actually looked for fellowships that I could do after family medicine residency, and there's like 2. And one of them focuses very much on like rural care for the seriously mentally ill, and it basically takes a year and trains you to like be good at all the antipsychotics. And one of them looks almost exclusively at kind of psychological issues in primary care practice, and one's in North Carolina and one's in Alabama. And so I looked at all the curricula of those, and basically I was looking for something that would be like a combination of that, because I feel like what we see in our regular practice is kind of a combination of that. So that's what's kind of motivating this and kind of some of our thinking about this, and we'd love to get more input from all of you about what would be useful in terms of continuing professional development for all of you. This person here is meant to depict all of us, not a mentally ill patient, as we confront things that in our practices that we really haven't been adequately trained to approach. And I think I've heard from a lot of people how frustrating they find it to be taking care of really vulnerable people who they feel that they can't help. So that's some of the background. Jose's experience, and when he arrives I'll have him speak more about this, is that he came to CMA and then through a relationship that the health center fostered with CMA, you know, to be kind of a embedded psychiatrist within our clinic. And he found over time that it wasn't a good use of resources to be one part-time embedded psychiatrist within our clinic. And he's going to talk a little bit more about that and about kind of how he's trying to reimagine his role. This is just to emphasize that we really do want it to be a conversation. We don't have answers to all of these things. And so I really welcome people asking questions and offering ideas and offering strategies that they've adopted on their own. The clinic as a whole has been looking at various methods of behavioral health integration. And there's a behavioral health integration task force that's developed over the last couple years, or months actually. And we all know that John Silva stood up and told us that one of his, you know, top 3 goals for the health center is to foster behavioral health integration. I really believe that there also needs to be practice change in addition to systems change, and that the behavioral health integration work that Mass Health has been promoting and that, you know, our clinic has been participating in up until this point has been kind of focused on systems without really focusing on the human practitioners within those systems. So, you know, we're hoping to kind of get down to that in the exam room level. So our agenda was we talk a little bit and then we all talk together much more about certain cases. I'll skip ahead. So that's Jose, he's coming. So this is me, the primary care doctor, who in any given time in a room, as you all are balancing a tremendous number of different agendas and inputs from patients. You know, I'll say a couple things about my thoughts about practice change in this experience of working more closely with psychiatrists, first with Luz Angela Rojas and then with Jose Ribas, is that I think I anticipated going into it that my learning would be focused on meds. And when people ask about feeling like our practice limitations, often people sort of focus on antipsychotics. Like when I've had other doctors ask about, oh, well, what is it that you learn when if you're going to be an enhanced primary care provider? And I think there's kind of a focus on antipsychotics, and I have found that I think it's much more about spending time with the diagnostic skills, particularly around depression and trauma. So the work that I've done that I've felt has been the most useful to me in my primary care practice, because I'm still seeing lots and lots of mentally ill people just in my regular 15-minute visits and not in my extended visits with psychiatric supervision, as we all are, is the ability to recognize various permutations of depression and feel more comfortable with, irritability that people describe, attentional issues that people are describing as symptoms of depression. And then related to that is kind of increased understanding and recognition of the ways that trauma cycles out in people's lives. And part of that for me is that I just am really have begun to question whether we can really provide adequate primary care for patients who have significant trauma in 15-minute office visits. And a big part of that is that when I have an extended visit with someone and I lay out what the agenda is and I'm able to say to them, you and I are going to sit in this room for 45 minutes, I think just by doing that, it creates a safer space for the patient. And I will find people who will just suddenly describe horrible rapes, just like that, because they have this more extended time and they feel safer. So I think those are kind of the two biggest influences that my time has shown me. Jose, I'm going to back us up to just show so you can see our agenda as well. There's you. And now I just want Jose to share kind of some of his experience about his changing perception of what his role should be in practicing psychiatry within primary care. So 5 minutes or so. Sorry to bombard you.
I can do that.
So that's that.
All right. Well, it's tough. It's different, and it's not something that I got trained for, that we really get that much training in psychiatry. And the reality of to get into the mental health system, you have to be well-functioning enough, or you need certain degree of stability to make it to appointments. So it's much easier to learn psychiatry in a clinic that if the patient doesn't show up 2 or 3 times, you fire them and then you're done. So this concept of primary care, if we don't fire people or we don't, always meeting the patient where they are, it's a little tricky. And I think it gets especially tricky for you because it's not just I will meet the patient wherever they are, but I want you guys to think I'll meet you where you are as long as it's safe for me to go there too, kind of thing. And I think the biggest point that I can tell in primary care is, well, when can I no longer be with you? It's like I'm not going to abandon you, I'm just going to, if you're going to fall off the precipice, I'm going to stay up here, and I'll have a rope ready whenever you want to climb back, but I can't. It's this line of where am I just enabling you or letting you, I'm primary care, I just meet you where you are, and I'll go over there, versus here I have to draw a line. And we've had many different discussions that are tough on what I can do, what's appropriate for me to do, and what's not. It would be much easier to say, well, what am I trained to do and what I'm not? And that's how we would want that to be guided, but the reality is not it. I mean, if you just do what you're trained of, Most of you are not trained in using and titrating and adjusting antipsychotics with the cogenting and the mood stabilizer and that part. But it's been this part of trying to invite you out of your comfort zone. Let's try these new things, and I can coach you the best that I can, because otherwise people with severe mental illness who need them are just not going to get them and will do worse off them. Wait, you can't be just giving all these substances that you don't know how to measure, that maybe, if anything, making things worse. So I don't quite know how to draw that line just yet. And what I've been doing so far is, or the new model that I've been doing is just a one-time consultation to at least give you some sort of guidelines, but you take care of it. That way I don't lose my own sanity. It's a lot of people to support. But I think that's where I'm trying to find the line.
Yeah. And I think you were talking, one of the things that you'd mentioned to me when we were talking about this presentation was the idea of, I think you were saying when you originally started, you had a perception of being able to triage out, well, this person is seriously mentally ill, and so, they're not appropriate, or this person is really personality disorder, they're not appropriate for this setting, and sort of realizing to the extent to which we are, quote unquote, stuck with patients, and that there's not really an option to move them out of our setting, especially just for their primary care. So, any questions about what we've said so far? Anyone want, before we move on to cases?
Yeah, I liked a lot what you said about the line that you draw. I think that's what we want to know. Where are our lines? Because we feel like we're just overwhelmed.
Well, each of you will have different personal lines too. I mean, even with residents, I see some are willing, it's like, well, this patient needs an antidepressant, help me, I've never prescribed one. Versus others will feel more comfortable, okay, I'm going to go through the guideline and say, you start an SSRI first, let's do that. Well, let me use the antipsychotic. Most people go, this person needs an antipsychotic, I have no clue which one to use. Versus, well, let's try Haldol and see what happens. And everyone's going to have a very different level of comfort. So that line is also a very personal thing.
Could you speak to Serena's question a little bit in terms of more behavioral stuff, or I have a case that speaks to that, but I think some of the knowing limits and setting limits also relates to not simply like the pharmacology. Or you can think about it and come back to it.
It's not easy, because when you also need some kind of structure support. I run into this in consults a lot in the hospital when I have someone who's using substances and lashing out at people and threatening and, I'll leave AMA. In the psychiatric unit, we're very good at that, because every action has a consequence. We all have, this is the plan, this is how things go, this is allowed, this is not allowed. When you're in a community health center, the patients get walk-ins. We encourage the patient to come in whenever they need. There is no, you missed your appointment, that's fine, I'll just see you tomorrow, I'll see you next available, or just don't see me, just walk in and see some other provider, and you will get seen. So it's a little bit of how do I do parenting when the parents can't talk to each other, or if there's 20 parents instead of 2 or 3 or 4. So I can name the challenges, but it's not as, especially with behavioral issues, it gets tougher.
Vince?
I agree with your statement that we should be more focused on making a proper diagnosis on that, rather than wondering which antipsychotic we should be using. But my dilemma is, whether I'm in the shelter or in the clinic, is where do we load this in? When many times our patients come with multiple comorbidities, which mental health is, especially in our population, my population, is very common. You have to sort out the schizophrenic and schizoaffective and bipolar. Try to make a reasonable diagnosis. And they're usually coming in and tell when they call me a bipolar. I like it just becomes very difficult. And how have you started to sort that out?
So I think I'll give an example, and I was thinking about running this person by you, and I haven't yet.
Live supervision.
I think some of it, and then this is where the question of like, well, who should get this additional training? How does this work? But having some more volume of experience of diagnosing mentally ill people has helped to make that diagnosis go faster for me. I do think that I'm now in my primary care clinic able to, just recognize some patterns a little bit better and have a set of questions. I think there's also a risk-benefit component of, well, and again, and now this kind of contradicts what I said before around like wondering about the antipsychotics versus, not. But on Tuesday night, my last visit of the night was an established care with a new PCP of someone who was previously cared for at our clinic, and then when she was cut off her narcotics contract in 2014, she left. She went down the road to another PCP, was there for 2 years, came back to us because she didn't feel like she was being helped. Fibromyalgia, multiple psych comorbidities. She brought paper records from psych hospitalization in December where she'd overdosed on Klonopin, and was coming in saying that the final straw that caused her to leave her prior PCP, and she brought the paper records, but she was a little chaotic in the way she spoke, and at 8:30 at night, or by the time I saw her, it was 9. Like, I was kind of like prepped to just be like, this is a disaster, like I'm miserable. And I actually, her big sticking point, I thought it was going to be narcotics or Klonopin, her big sticking point was that she really wanted some Seroquel because that was the thing that had helped her sleep in the past. And I don't have a clear diagnosis on her. I talked to her, does she have, I felt able to do a review of systems quickly that demonstrated to me that I do not think she has true bipolar 1. She reports no, she has it on her problem list. She reports no true mania ever. And, so I felt and she came in on no mood stabilization. She also hasn't, despite this hospitalization, she didn't have stable psychiatric care afterwards. So I felt comfortable saying, okay, I don't love Seroquel as my sleep aid of choice, but this woman's, not currently says she's not using, but previously has used, in terms of risk benefits and harm reduction, I would much rather throw her some Seroquel and then see her in a couple weeks, or actually I'm booked to see her next week, and have more of a diagnostic conversation. And so I often will book, and this is in the shelter, you don't have the kind of people showing up all the time. The chaos is great. But I will often give people the chance and say right up front, I'm not going to be able to figure this out. And for her, I was saying I was doing this because she had no established psych care. If she told me I'm seeing someone at Arbor, I would have said, you really need to continue to see that person at Arbor. If you have a prescriber at Leahy, go back and see that person. I shouldn't be messing with your meds. That will just get confusing and dangerous. And if you, but so kind of three-pronged answer to your question, Ben. Some of it is I do feel like with some increased exposure, I feel a little bit more comfortable, and I feel more comfortable with my ruling out of mania, and that's something that perhaps we can think about helping people to get more comfort with that, because that's just so common that people come with this bipolar diagnosis, and it is bunk. And so one is a little bit more comfort just from exposure and teaching that, maybe we can think about as a clinic providing. 2 is kind of dealing with the acute situation of I can't sleep, okay, what are we doing for that? And then giving people close follow-up if we're able to do it in our schedules, and saying to them, that's going to be the visit where we talk about this. And then I have had visits where then people come with other things, and unless it's an emergency, I say, oh, no, your mental health is really important. We're going to talk about this in those 15 minutes that we have. So, I don't know, it's kind of not a totally satisfactory answer.
Not even that, I want to say, sometimes I get those consults of patients asking for Adderall, please see if they have ADHD, which are fair. It is a fair question, but regardless of there's so much the interview will give me that's going to lead me towards prescribing Adderall or not, as much as, well, who did you see first? What happened in the last 6 months of your life? Why is there this gap? What do you mean you just moved to Lawrence? From where? And we have, and I will not even start my ADHD interview or talk about symptoms until, wait, I see we don't have those releases. So who were you treating? Who was giving you? I don't see anything in your PMP about that. And I've spent my 50 minutes, luxury minutes that I have with patients, just coordinating, getting sure this isn't moving forward until I get this. And then if they leave, it's like, well, so where's my Adderall? I'm like, we need this work first. I have to. And then it's tough, because if you have someone, I mean, ADHD, at least the one thing I always say, doesn't cause subjective suffering. People don't suffer because they can't pay attention. People with, that's amphetamine addiction, that you're craving the amphetamine, that does cause suffering. People who have severe ADHD, they're just happily unaware of it. It's pretty close to dementia. Drives everyone else insane. Drives me insane talking with someone with ADHD. And it's like, please take this and come back so I can get a linear story. But the other thing that primary care I see finds more difficult, and I think when I talk to pediatricians, I think someone gave the example of, if you drop your keys over there and you're looking for them here, I say, hey, let's go over there where your keys are. And someone gave me the example, well, no, like I'm trying to go and fetch the keys for the patient kind of thing. So this part of putting the burden, the proper burden on the patient of, wait, for me to do this, I'm not going to go down the cliff. I'm going to be here with my feet well grounded. But I agree you need that. And how do we do that?
Any other questions before we move on to psychiatric? Yes.
With kids, it's a little tougher.
Yes.
Yeah.
Because you can't say that to a child.
Yeah.
No, that's why I don't deal with kids.
Suffer. They suffer in school a lot.
I cannot deal with it.
Yes.
Honestly, no. I will not be helpful here.
It is, and for the kids that I see in my own practice, I do find that having, the big thing is getting the Vanderbilt back, getting the parent to be that coordinated. I have found just that you have a wonderful MA, so I'm sure that your MA is helping you with this, having the MA help with the coordination of that. Do you have other tips from your practice around ADHD for helping to kind of...
I have avoided making the diagnosis and starting medications myself forever, because I think it's so complicated. There's so many other reasons that kids can have ADHD, and also, even if they do have it, it has all of these comorbidities that makes them terrible. They need a therapist. They need a team. I don't have a team. So I try to get them into care. I really think they need a team. Some people don't feel that way, and they just give them the medicines, and so I know who those people are. And I send kids there, and I say, you can just want the medicine. You can take your child there. And then I tell them places I think are good. The place I get stuck is they've been stable on something, and the psychiatrist dies, moves, gets fired. I don't know what happens. And here's this kid who's been doing perfectly well, but it's not the parents' fault. Or they had an emergency in the DR, they went and they came back and they were out because they missed a couple of appointments. So I've found myself lately prescribing medicines, and I say to them, I'm not going to change it. I'll drop it if you think it needs to be dropped, but I'm not hiring the book, raising it, I'm not changing it. And you have to come every single month to Vanderbilt, or you can't get your meds. I'll give you 1 month at a time. And every month you're going to tell me all the places you're on the waiting list. And I'm only doing it during the school year. So it's kind of draconian. I feel terrible doing it. But I do manage to get kids into care. And the latest problem that's really bothering me is that I come with kids who aren't just on one medicine. They're on 5. And they see my least favorite psychiatrist in Lawrence. And, something has happened, and somebody just died recently. One of the people who prescribed just died. So here's this kid with all of these horrible medications that I don't know how to do. And I don't know what happens if we stop them. So this is my question. I've just been giving them the same doses. I call the pharmacy, I make sure that's the doses. Parents bring in the bottles. And then I start the same month thing that you have to go. Here are the places to go. I want you to go to St. Anne's. Go big, call every week. And and the parents can either get it together to come every month or they can't. And I don't know what to do about that. But I feel really stuck.
Have you called MCPAP?
I haven't decided if I want to get that involved.
Okay.
Because I have so many other patients to take care of with other issues.
Yeah.
And I feel very conflicted.
Yeah.
I think probably a lot of us feel really conflicted about how far into this do we want to get. With it, if we get very far, we need a whole bunch more training. We don't have time to keep up with our notes, never mind, CPDs. I really feel stuck. And on the other hand, here are these kids in front of me. Yeah. And then you have the ones that throw things at Haverhill Street, and the police find them in Bedford and take them to Mass General, and they get admitted for 2 weeks. Some of you probably know this case. Yeah. And then they come back to you when they're 18. Parents don't have guardianship. The parents are like, finally, in desperation, I didn't want to do it. There's some DCF for adults. I forget what it's called.
For disabled
people. They were shocked that I called them and said, here's this kid that carries a diagnosis of ASD, and he's really, really, really schizophrenic. He's covering his head because he doesn't want the voices talking to him all the time. Really, really. And I did have a psych hospitalization to say that. So I called him up and said, here's a kid who, he should be at school till he's 22. He needs services. He gets into them, we get him appointments, parents don't take him. I can't call DCF, he's 18. And they were shocked that I was calling them. They were like, whoa, what are we supposed to do?
DDS was? You call DDS, which is the agency for this, touches on a couple things.
For elder abuse too, or adult abuse.
Yes. There's 2 separate ones.
So I found out who it was. I can't remember now.
Okay.
I remember someplace, and I called, and they were kind of surprised. And so I didn't know what else to do.
Yeah.
Because we'd gotten him to a hospitalization. We had appointments with psychiatrists in town, which is where they want to go, which is impossible to get. And they didn't go. They went to see me, and I didn't know what to do.
Yeah.
Because this person needed help, and the people in his life weren't helping him. So then I just let go, because, I don't know what to do.
Yeah.
But it's very unsatisfying.
Do other people have comments or questions about that?
I've used several times.
Yeah.
I find them to be very elementary. Like they talk to you like you've never done this before. Oh, well, she would feel better if she took her Zoloft. Yeah. Well, she just needs to take her Prozac. You just need to keep going up. Like you go up by 10 milligrams every month until she's at 80 milligrams. Check an EKG at 60 milligrams. But not how do you get them to take the medicine? How do you get them to keep their appointments?
Oh, we don't know that. No, I want to go back to my training. If you don't take your Prozac every day, you don't make it to the psychiatric clinic without not having 2 no-shows in a row. So we don't have that expertise either, I'm afraid. You guys know more than psychiatrists when it comes.
At your door.
Exactly, we close the door on them.
I know, but we don't.
We don't have the answer. That's exactly what I want to hear.
I do think, though, that you're underestimating the way that you talk with patients about SSRIs and starting SSRIs, and the amount of time that takes, the amount of follow-up appointments that are scheduled, the amount of talking, ideally someone who started on an SSRI should have a follow-up appointment within a week to talk about the side effects of the meds. They are meds that people will feel, especially if you started anything other than a low dose. And then a lot of people, they feel anything and they just stop it.
And you see I use the drugs less as a pharmacology aid and more as a transitional object. It's like, well, I sat with this person who saw my sufferings, who understands what I went through, who made room in his reality for me, and it gave me this. So every time they take the pill, they're kind of trying to reinforce this. I felt good talking there, or I had someone who thinks that I can get better. I don't want to fail him. Like, there is all this other psychodynamic or subconscious thing going on behind the pill. So I'll say the pill is as good as the person who prescribes it in that way, and how you prescribe it, and how much faith you put on it, more than the direct pharmacological effect. I did want to make one more comment on this thing about the psychiatrist dies, and then what do I do, and I just continue thing. The psychiatrist not only has more training, because the knowledge base, when it comes to the pharmacology, it's not, you guys know this already. I mean, you know how amphetamines work, how benzos work, how no one knows how antipsychotics work. But it's not just our training that allows us to prescribe something that may seem outrageous to you, but the other things that come with getting to see the psychiatrist. So for me to give you, let's say, 2 of Klonopin twice a day, which is not something that I would give in primary care, but it's something that I can give in a mental health clinic when I already know, because when I see the patient, I have all the notes that he's been going to therapy. I have my staff that's already trained, DMAs that collect the drug screens regularly. I don't have to go like, well, I need a drug screen, and it's already a given. With if you're try it a little bit. Sometimes, just to get into the psych, the same way we ask for medical records or a referral, getting a drug screen is pretty standard when you're gonna get a psychiatric evaluation. It's just the same way that in the emergency room, I don't even see the patient until I have the Chem7, the drug screen, etc. And that's not a standard here. Here it becomes, I tried to do that here with patients, and they were just leaving. It's like, well, this doctor hasn't seen me, and he already wants my urine. Like, F this, I'm not going to do this. And so it's different rules. It's not, which only complicates it more, because it's, wait, I'm just going to prescribe whatever the other person was giving them before. I don't know if that other person would prescribe it if he or she were in the primary care office without all the other safeguards. So it's that makes it even more complicated.
So
in case
you just let them stop cold turkey. Is that what you're doing?
I don't know that helps them either. That's so it's this part of what is safe. So if there is something that I consider pretty outrageous, it's like, we can't do this. Like, or if you want to, usually people who want to be on amphetamines and benzos at the same time, that's I've said as a rule, I will not do both from a primary care office.
But we did it last week.
That is doable, because I'm teaching you to break the rules. So they're learning the rules, and then you learn how to break them, and how, and where.
Just saying.
Yes. Well, I said I don't do it. I don't say I don't tell other people to do it. But
Easy for you.
That's one rule that I've found useful, rather than say, no, you don't need this, or no, this isn't good for you, or no, I'm not going to give you this. It's like, sure, that may help you, and you've seen other people and being on that for 20 years, and that's great, but from this location, this office, if you need both, that just tells me how severe your psychopathology is, and that's why you need to be treated by a specialist in the proper setting. So I will, which one do you need the most? And unanimously, it's the benzos. So, okay, this is how much benzo I think is reasonable, or this is how much we can do. And I'm going to give you this until you get in care here. And I've had patients that after 6 months, they still haven't gone for a walk-in at Leahy. And I've said, I'm done. Like, it's something that they keep hearing, well, what? I don't hold them to the give me your progress report every month, although that's a very good idea. I just don't know that everyone is high functioning enough to do that. But it's, I don't think it's inappropriate after a while to just say no. With another resident, we had a conversation. She was giving, I think, Depakote to a young bipolar patient that was out of the hospital and whatnot, but still wasn't on birth control. And we're going to start the conversation. You clearly need the mood stabilizer, so we're going to do this, but it's like, we can't keep this going on. And now it's a few months have passed, and we had the conversation again with the resident, and it's like, we're just we can't, this is just not safe, we can't keep doing this. So be aware of that.
We have about 10 minutes left, and so we haven't done cases I prepared, which I think is fine. I want to speak just a little bit to the MICPAP quickly to say that they have a different psychiatrist every day. I have most experience with the Mondays and the Wednesdays. The Monday is a very different experience where he says, yeah, just if you feel like the kid's a little anxious, give them a little of that. And I'm like, how the hell would I know what an anxious 6-year-old feels like? So I've had the opposite experience of, but then I also, the Wednesday person is a little bit more elementary, as you were saying.
And Randy, I was like,
I think I know who you're speaking of.
I want to call
Do
now.
try MCPAP if you can. If you Google MCPAP, you get the phone number for PCPs. Does everybody know what MCPAP is? Okay, so it's the Massachusetts Child Psychiatry Access Project, and it's run by DMH, and it's funded by DMH money. And this is what the state of Massachusetts has decided is the answer to the shortage of child psychiatry. One of the reasons I think it's important that we try to use it is because we need to be able to feed back to the state of Massachusetts if this is where their resources should be going. I'm on their advisory board, and so if you have particular experiences, let me know, and I'll try to communicate with them. I've complained to them about a few things. It's premised on there is a psychiatrist on call for our region, thank you, in Salem, New Hampshire, and they will consult with you over the phone or they will do one-time consults with your patient. And I, in one case, have actually gotten a 3-time consult, like where they've gone back each time because they were wanting meds that I just didn't feel comfortable adjusting. And for a case like what you're describing, Serena, where someone came on meds and then you're not sure how to adjust a dose, I actually think that's a perfect MCPAP case that could be fairly straightforward from them, that it's, you have to increase the dose because the weight has changed, or, that actually is where they can be helpful. Someone who's already been diagnosed in the system, got some relief with a certain med regimen and making adjustment. It's much harder with the people where you're like, I think that they've got this going on, they've never been in the system before, they've never been diagnosed, and mom has been difficult to work with, and that it's much harder because you end up with the, well, how do I make them take the Zoloft that I think they should take, or are they actually depressed, or, and those are the people that I fight a little harder to have them see, and I have found their consult notes to be quite useful when they get seen, and Mass Health will provide transportation to get to Salem.
so they'll call you the same day they see.
Yeah. Yeah, and the commitment is that they're supposed to call back within a half hour, and often I've called down and gotten directly through, like the administrator just puts me through and I talk to them at the same time.
And it's Fatima is the administrator. She's been.
Well, I've talked with Antonietta. Is Antonietta gone? Or, okay. But so the administrator speaks Spanish, so she can also set up appointments with our patients effectively.
No, my patients have been seen in Salem, Mass.
It's Salem, Mass. Oh, did I say New Hampshire? It's Salem, Mass. It's not close. It takes quite a bit to get there. Ellen, did you want to?
Just from a practical standpoint,
Yeah.
how do you get a child to
You talk, so you call to do the consult, they'll talk to you. Depending on which psychiatrist you talk to, they may be like, oh yeah, we don't need to see that child. But if you really feel they need to be seen, you say, I really want you to see this child, and then Antonietta calls. After that conversation, Antonietta calls the family and sets up an appointment. And then they can work with Mass Health to get transportation. So it depending on the psychiatrist you speak to, it may take a little pushing, and sometimes the compromise is that they'll have them seen by their clinical social worker, and then decide if they should be seen by their psychiatrist, which I also think the clinical social worker reports are very helpful, so that is not a bad thing. So we didn't touch on a few other things. If we were to talk about one issue, psychiatric emergencies, care of the seriously mentally ill, or family dynamic stuff, which one do people want to talk, or does someone have something else they want to ask about? Anything else?
I think there was a slide up there about the Department of Mental Health.
Uh-huh.
Get them involved. I think that's something I'm sort of unsure about. So
Okay. So, yeah, so that's kind of related to our discussion of the seriously mentally ill. So the case that we were talking about with that one is, there's kind of two different scenarios. One is someone shows up with their DMH worker, and then the DMH worker is saying, can you prescribe these medications that they come from, because they saw someone inpatient. Have people had this situation? Okay. And what was your experience of the situation when they show up with?
Several people like that now.
Sorry?
Several people
Yeah.
like that now from Holy Family.
Yep.
And I just, I don't have enough experience to do it. I say I'll be a bridge. And, I don't want people to fall through the cracks.
Yep.
But I feel, I feel like I'm nervous about it. I feel like I'm on thin ice, but I don't want to, So I just try and do the phone calls and be sure that there is some appointment, with a community psychiatrist. And I'm doing it, but I would, and then just other people just coming in psychotic, just so sick and suffering, really. I just feel like a little extra help if we could have some rounding at the clinic, to go through cases once in a while. Some sort of support would be really invaluable, because I don't feel right about saying no, and I don't feel confident to say yes,
To the prescribing of the medications? Yeah. That was very well put. So, and when you're saying being a bridge, what kind of things do you do to be a bridge?
Well, I have 2 people right now on Invega coming out from psychiatric ward. I have somebody, I just got a call from South Bay, I think it was. The psychiatric prescriber is leaving. They're not going to have anybody until September. She's stable. And I said I can monitor the medicine, with labs, and I can prescribe the medicines, but I can't adjust them, and there has to be somebody to take over, and if something goes wrong, I can't do anything. So that's the approach I've been taking, but I saw a lady yesterday, so schizophrenic, so, demons after her, eating her was awful. And no insurance, of course. So it's just so hard, not to be. If somebody's depressed, I know how to use an SSRI. If somebody's psychotic, I don't know how to help. So.
And the uninsured, seriously mentally ill are.
Well, no. So why did you sign up for this? I mean,
we didn't. That's the title of the talk.
Which I think is that's the part that I'm interested in, just learning about you guys doing community mental health, which translates into doing community psychiatry, or not doing it and then just watching them be psychotic and manic in your office while you try to deal with the other issues.
Were you? What were you going to ask?
Well, something that I have found helpful, particularly in watching you over the past few months take care of some of my patients who I've sort of, been at loose ends with.
That's tough patients.
So one of the things that you do that, I feel like I could do too, and it's sort of a little bit of an aha, it's you take more time, not only with them, but also recruiting a family member and getting a release and saying, I'm gonna, we need to, someone that's I have a patient that's basically in psychotic for years. He's sort of pleasant, and so we have these visits. I have, I don't know what's going on. We have an interaction. He goes. He comes back a few months later. We have a nonsense conversation. He goes. He comes back, and you sort of made me realize, I need to have a family. It's totally unreasonable to be taking care of it without a family.
He called his family member from the waiting room while holding the waiting room hostage, so that helped. She showed up.
I think of a different person. But just sort of recruiting family, really taking the time, as you talked about, to get the story really clear. Because people come with 3 or 4 different diagnoses, and it's hard to tell which one, and sort of walking it back and figuring out, what was actually the conversation that led to the most recent diagnosis, and just doing some practical things, giving yourself some space to do some practical things, I think has made me feel a lot more stable taking care. It doesn't really change in some fundamental ways the situation, but it gives me more confidence, I think. Kind of taking care of people, just doing it's not so much that intellectually I know a lot more about antipsychotics. It just sort of, if I'm going to be involved in a prescribing relationship with somebody about medicines where I'm not that comfortable, to sort of broaden the non-pharmacologic, field of play a little bit has made it more comfortable. That's something I've really kind of learned from you guys.
Something we can do with more supports, we just don't have them, and more time, Like, I have the luxury of the added time, and that's not something that we all have.
Right.
I wish that we did, and
Well, and I guess I sort of feel like
that.
I spend enough non-productive time, like over time, if you add up 15 or 20 or whatever minute visits that go nowhere, it's worth at some point to say, okay, I'm just going to bite the bullet on this one and maybe double book them or something.
Like what Jose was saying about, like, this stops until I get all these releases.
I mean, there's people I don't believe a word they tell me.
Yeah.
And there may be some unconscious biases there, but there's just, you just keep contradicting yourself, and how subjectively bad your anxiety is just not useful information for me deciding whether to prescribe a controlled substance or not. Rather than do that, I need your records, or who do you live with? Are you living with your parents? Can your mom call me? And you will usually see people living with him, like, God knows, stop, like, she just takes handfuls of meds, and like, by night she has her cabinet that does the thing, and so get the useful information and don't wait. The face-to-face sometimes doesn't give you as much.
So we should close, because we all have patients. Any other comments, questions? My last slide was sort of asking people, to think a little bit about, now that you've sort of heard what we're doing and what we're thinking about, what other things you think would be useful, like what you were saying about the rounding idea, or what kinds of topics you would like us to prepare a more formal presentation on, and then other questions, and feel free to email us.
I think from the resident perspective, we learn about SSRIs, and we have the chart of SSRIs and their side effects, and it'd be nice to see what counseling you do, because I feel like we don't get that piece, like in terms of like just our first year, like shadowing and seeing what type of counseling you do, what type of side effects you counsel on, because I feel like that piece, like, I don't do really well.
Okay.
I think, like, who are the people who get these DMH workers? If we have someone who we feel like would benefit from that, how do we plug them in and take that path?
So most recently, Hillary Lennon has been helping me get a patient plugged into DMH. She's my team's CCNC, clinical, what do they call it? Clinical nurse coordinator?
Coordinated.
Thank you. Coordinated. Thank you. It involves some paperwork and some phone calls. If someone has schizophrenia, if someone has severe bipolar 1, they really should be eligible for DMH services. And so if there's someone that is not plugged in, unfortunately, we don't have a social worker at our clinic. We don't have social workers. We have social services, but our social services staff is not equipped to help someone get into, for example, DMH services. And in other clinical venues, the social worker is the person that does that. So we have a big gap.
I've used Berta for that. Like,
you have to get into DMH?
Yes. Well, no, because then she would make an appointment that they won't show up because they have severe mental illness.
Yeah.
So that's the. But she has the technical skills to do it.
Much more skilled at the asynchronous care of, like, okay, I'm calling this DMH worker, I'm describing the situation, we're getting that person in, and then so reaching out to whoever in your clinic is that person, and if you have a particularly skilled nurse. Or someone who's like a good advocate nurse, like Marlene Perez on Red Team is very good. Like, they are also able to kind of reach out to try to do some of the asynchronous care work, and just call. Basically, you start by calling DMH and presenting the case to them.
Yeah, like, I've been training my young MAs on that. It's just that then they leave once they learn the skills.
Yeah.
But filling an application is something that an MA can do for you for the most part.
And relatedly with FinFen, like, what is FinFen?
Yeah.
That's the DMH housing. So to get into VinFen, you have to first be a DMH client.
No, but there's also like VinFen nursing and Point After Club, and they're not just housing.
That's kind of their base.
Yeah.
They have all the other.
But you could, again, like if you put in a VNA referral for a mental health diagnosis and then routed it to the right nurse or the right CCNC, they should be able to help you with that.
But it'd be helpful for maybe them to come and tell us like what they do for our patients.
Yes.
And like I would love to know sort of like how to counsel people, like what this is going to be.
Yep.
Like I think that'd be really helpful.
That would be really helpful.
And likewise, all the point after clubs, and all those things, just sort of like having a better, clear understanding of what it is they do for our patients.
Yep. Point After Club is part of VinFund, just FYI.
And how about getting social workers? I have a social worker at my clinic, and she really helps.
Yeah. I'm a big believer in, well, so she's a clinical social worker, so she actually does counseling. And then even if we didn't have those, if we had social workers that did this kind of resource plug-in, it would be huge. And I've brought that up at behavioral health integration meetings a couple times. Yeah. Thank you, everyone.
Thank you.